Hi, my name is Dr. Rob Rozbruch from Hospital for Special Surgery, and I'm going to discuss with you the treatment and approach to ankle arthritis, when to perform distraction, fusion, or replacement. So there are basically three main surgical options for the treatment of advanced ankle arthritis, and as this slide indicates, there are sort of optimal indications for each one, but there is a degree of overlap that is apparent, and I'm going to try to illustrate some of that for you. So my algorithm for surgical treatment of ankle arthritis is listed over here. I kind of have what I would consider the optimal patient for each procedure, and I'm going to go through each one of those separately. So ankle distraction and joint preservation is ideally suited for a patient who has a mobile ankle and who has moderate to severe arthritis. The patient can be young, or the patient can even be a bit older as well. So here's an illustration of a before x-ray where you see advanced joint space narrowing, and after ankle distraction on the front view and the side view you can see increased joint space, improvement of the subchondral bone, and really a joint that just looks so much better and more healthy. Another example, this is a patient who presented with arthritis of the ankle. There's an equinus contracture, which means that she can't get her heel down to the floor. You can see the arthritis particularly in the front of the ankle joint. The patient wears the ankle distraction frame for a period of 10 to 12 weeks. It is a hinged frame, and so we encourage weight bearing and we encourage range of motion. At the end of the treatment, you'll notice the improved joint space. Another patient, an older woman, prior to surgery with joint space narrowing and osteophytes impinging in the front, and after distraction 1.3 years later, you see a big improvement in all of those features. We've looked at MRIs on our patients pre and post-op. You see a typical example of a preoperative MRI with advanced joint space narrowing, very minimal cartilage in the front of the joint in particular, and subchondral cysts. Those are the round structures that you see on the MRI. 1.3 years later, you'll notice that the cysts have been resorbed and there's increased cartilage in the joint space. That is the gray between the talus and the tibia. And on the side view as well, you'll notice an increased zone of gray, which is the regenerated cartilage. We use microfracture and stem cells as an adjunct in our treatment. Areas that have bare bone are typically drilled to enhance the cartilage regeneration that is apparent, and then the addition of stem cells further enhances that. We obtain the stem cells by retrieving bone marrow, which is a relatively simple thing to do during surgery. We centrifuge it and concentrate it, and we obtain your mesenchymal stem cells, which are then injected into the distracted joint. This is what the ankle distraction frame looks like. You can see it has the ability to distract by adjusting the nuts, and it's a hinged frame. This is a frame that we developed. It's called the RAD frame, and it is manufactured by Structure. This is a illustration of the hinged frame showing the movement while the ankle is in the distracted phase. This is a 40-year-old man, active guy, played D1 college football. You'll notice joint space narrowing, particularly in the front of the joint with anterior osteophytes, pain, limited motion. After distraction and removal of the osteophytes and microfracture, there's more joint space. This is the before x-ray, and this is what it looks like after the frame has been removed, and you'll notice there's increased joint space, cartilage regeneration, and decreased osteophytes. Functionally, the patient is doing quite well with excellent range of motion. and an improved ability to walk without pain. Another patient in mid-30s, you'll notice the anterior subluxation of the ankle, the advanced joint space narrowing anteriorly especially, and then after improved congruency of the joint and improved joint space as well. So the next step in the algorithm is ankle fusion. Ankle fusion can be done with internal or external fixation, so I'm going to discuss with you more simple ankle fusion with internal fixation. And who is this indicated for? Well, this is for a patient who has advanced arthritis of the joint, where the joint is very stiff and there's really no movement of significance, and in a young patient. So here's an example. Regina, at the age of 40, had advanced arthritis of the ankle. It was a very stiff, painful joint. You'll notice there's a deformity with talar tilt. This was treated very effectively with a simple ankle arthrodesis using a screw technique. Since she started off very stiff, she really didn't give up any mobility. The only thing that she lost with this procedure was pain and discomfort. Another patient who I treated with ankle fusion, this is Tim. He's a young 30-ish-year-old male who had severe post-traumatic arthritis. And you'll notice when we do our CT scan that he's actually missing quite a bit of bone. And this is going to be treated most effectively with an arthrodesis. Here we did a different technique using a plate, and that's because of the bone loss that I had shown you. This is a follow-up x-ray several months later showing a solid ankle fusion that is successful. We needed to do some bone grafting to fill in the bone loss. The next step in the algorithm is ankle fusion with external fixation. When do we need to use the external fixator? And it's when the ankle is severely damaged. These are unusual, severe cases. Many times they're limb salvage cases. There's usually bone loss, and in many cases there is infection. So here's an example. Gabrielle presented with an unusual situation. She had had a trauma many years earlier and had lost her talus bone. It had been dislocated and removed by the trauma, and she underwent an unusual innovative procedure with a total talus replacement. Now this worked for her for a number of years, but it led to severe erosion of the tibia and the calcaneus with pain and limited mobility. So the problem here is that she needs a fusion, a tibia to calcaneus fusion, which is not a typical and more complex fusion, but also there's bone loss, and she needs to make up 5 centimeters of length. So there's bone loss from the talus implant, erosion as indicated. And what you see here is Gabrielle standing. You see the external fixator on the distal part of the tibia used for the tibia calcaneus fusion. And then to make up the length, she had a precise internal lengthening nail that was used to gradually lengthen the tibia to equalize the leg lengths. The bottom is the frame, the external fixator. The top is the internal lengthening nail. Here's what it looks like once it was all healed. You can see there's a solid ankle arthrodesis. That is a tibia to calcaneus ankle arthrodesis. And there's solid healing of the 5 centimeter or 2-inch lengthening of the tibia. Her functional result was excellent. Her leg length equalization and ankle stabilization was excellent. This resulted in excellent gait, equalization of her leg lengths, and a great functional result for her. And finally, what is the role for total ankle replacement? Ankle replacement is an exciting option, and we reserve it for older patients who have a mobile joint. So we're not doing it on young patients because How long these implants will last is not entirely known at this point. So we're not offering them to young patients, but for an older patient who has a mobile ankle joint, they're a very good option. So here are a couple of examples. You can see Ed at the age of 71 presented with excellent range of motion of his ankle, but advanced arthritis, pain. A total ankle replacement. Here you see the STAR, S-T-A-R, total ankle replacement done. That's the side view. And what you can see is this is a neutral position, and this represents approximately 50 degrees of range of motion in the ankle. Romano is another patient. You'll notice these x-rays go back to 2006. I met Romano a number of years back, and initially we treated him with an ankle distraction. He actually had an excellent result from his ankle distraction with increased joint space and improvement in his symptoms, and it lasted for 13 years. But then 13 years later, once he was an older gentleman and he started to have increased pain, the conversion to ankle replacement was a good option for him. This is the x-rays and surgery, and these are the follow-up x-rays. The concept of using the ankle distraction to buy time and delay the need for an ankle replacement until the patient is older and a better candidate is a concept that we do believe in. This is a textbook of mine that illustrates a lot of these kinds of cases. If you're a professional, you may find this to be an interesting resource. So in summary, my algorithm for the surgical treatment of ankle arthritis includes ankle distraction and joint preservation for the mobile ankle with moderate to severe arthritis, ankle fusion with internal fixation for the young patient with stiff ankle with advanced arthritis, ankle fusion with external fixation for a severely damaged ankle with bone loss, infection, and in many cases these are limb salvage cases. And finally, total ankle replacement for the older patient who has a mobile ankle. So we do have an algorithm. We like to pick the ideal operation for the individual patient. There is some degree of overlap, and it's not always so absolute, but this is the algorithm that we are generally using and have been successful with. I want to thank you for your attention, and I hope that this has been helpful for you.